Hello, my name is David Kooby. I'm a surgical oncologist with Emory University and the Winship Cancer Institute in Atlanta, Georgia. I focus on gastrointestinal malignancies and primarily on foregut malignancies, which would include malignant tumors of the benign and malignant tumors of the liver, stomach, pancreas, and intestines. So I get asked sometimes how many organs can I remove at surgery if I'm faced with doing a multivisceral organ resection for any tumor type, and specifically for a potentially more indolent tumor, such as a neuroendocrine tumor. And then the question comes up, is organ transplantation a possibility, and how do you make that decision? One disclaimer, I'm not an organ transplant surgeon, but I work with organ transplant surgeons. So sometimes some discussions come up between our groups where we have a patient who might benefit from my services for removal of the malignancy, and then from my transplant colleagues for consideration of transplantation. And sometimes there are cases where the only way to remove the tumor would be with a resection and transplant at the same time. So if we take a step back a little bit, the first thing, we have to have the elephant in the room with many patients who present with neuroendocrine tumors is that they have a chronic disease, and there's a good chance that they will not be cured of their disease. But most of us are not cured from hypertension or diabetes or arthritis and those conditions either. We live with them and we get treatment when we need to, and we see our physicians and our clinicians periodically in order to maintain, or optimize our health. So once you get that discussion in the mindset of, especially for a more advanced tumor type, that at least the patient understands that they're facing sort of a lifelong endeavor. So because of that, then you have to decide what's the right amount of force to use for what problem. So looking at the neuroendocrine tumor is really the paradigm for deciding on level of force, because we do pretty big operations for these tumors, such as Whipple resections or removing nearly all the small intestine, and sometimes having to do an extensive liver resection, et cetera. And sometimes we're faced with doing this with a very small tumor, primary tumor. So then the first discussion is, do they need surgery at all? Once you get sort of past the indication, you're saying the tumor is aggressive enough, it's going to be a threat to them because they are young enough that this will eventually evolve and turn into something that's going to progress and be a problem for them, then you have to look at a few different things. So any of the patients who come to me, the first thing I do is I have to answer 3 questions. And the 3 questions are, 1, can the operation technically be done? 2, are they in good enough shape? And 3 is, will it help? And if you take those 3 questions and you break them down, the first one is, if any one of them is no, it can't be done, no, they can't tolerate it, or no, it won't help, then you shouldn't do the operation. If you have 3 yeses, you proceed. The reality is you get some maybes. Yeah, I think I can get that out. I think they can tolerate it, and I think it'll help. So then you have to have the informed discussion with the patient to decide how aggressively to proceed. So now if we're talking about getting to the point of transplantation and multivisceral organ resection and transplant, the question of, can it technically be done, is the first one. And the way you have to look at that is, can I take out what I need to in order to get the tumor out completely, but leave the patient with what they need to survive and have an appropriate quality of life? So small bowel is a great example. If I have to take out, 2/3 or more of the small intestine, the patient is going to have prolonged symptoms of short gut syndrome. They're going to have diarrhea, malabsorption. They're going to need to be on supplemental nutrition such as TPN, and that may be lifelong, and it may be a balance. And then, if their prognosis is good and they're young enough, that's when you might consider organ transplantation. Again, I don't do that, so it would be a referral from somebody like me to an organ transplant group. There are some data published on this, and if the biology is favorable, if it's a slow-growing tumor, and we get in front of it with this big operation, then consideration for organ transplantation might make sense. Liver metastases from small bowel carcinoids or even pancreatic neuroendocrine tumors may occasionally be considered for liver transplantation and with potentially good results. But there are basic criteria, just like there are the Milan criteria for removal of hepatocellular carcinoma when it's in the liver. Same thing with neuroendocrine tumors. You want to see that less than about 30% of the liver volume is involved. It might even be lower than that. You want to see that they have relative stability over a period of at least 6 months, and that the patient otherwise meets criteria for transplant based on baseline health and age and functional status. You also have to have organs available for these transplants. Just because a patient may be a good candidate for a complex resection, multivisceral organ resection and a transplant, well, you still have to be able to transplant them. You have to find a suitable donor. So those are very complex issues, and there's not going to be a one-size-fits-all to address that. As far as how much of an individual organ can be removed, really depends on the organ. Typically, we don't do partial splenectomies, for example. It can be done, but it's not typically done. So in that case, that organ can be completely removed. If we're talking about removal of the small bowel, I mentioned already that when we take out a good amount of small intestine, then the more we take out, the more symptoms the patient's going to have. So if we start off with 6 meters of small intestine and we take out 1 meter, probably no big deal. When we get out to 2 meters, the patient might have some symptoms initially, but the body will accommodate, and their absorptive surfaces will increase with time, and they'll be able to tolerate it. When we're getting out to 3 and 4 meters of the 6 meters that the person's starting off with, the symptoms become more profound, and they need more support to improve from it. And by the time you leave a patient with less than 150 centimeters of small intestine, then they're probably going to have some lifelong battle with shortcut syndrome, and transplantation may be a consideration. Lastly, I'll mention the pancreas. Yes, if you take out 80% of the pancreas, a person who has a properly functioning pancreas may have no symptoms whatsoever. They may have perfect endocrine and exocrine pancreatic function. That's not the case for everybody, but if their baseline function is good, they may still be okay. But if you take out the entire organ, yeah, they can live without it, but now they're going to be a difficult to manage diabetic, and they're going to have malabsorption, of which they have to maintain on pancreatic enzyme replacement therapy. So it can be managed. I think ultimately, as we head into these operations where we're faced with removal of vital organs and organs that will have significant effects on their lasting function, we need to know our patients. We need to have these discussions up front. What I typically will do for instance, in the pancreas situation is I will refer the patient to a savvy endocrinologist to have that discussion ahead of time, that if Dr. Kooby is going to remove your entire pancreas to remove an appropriately positioned neuroendocrine tumor, that this is what life is going to be like. We're going to be talking about insulin pumps. We're going to be talking about pancreatolipase replacement therapy, enzyme replacements, so that you can digest your meals and carry on with a reasonable function. And certainly a patient who's not going to show up for a follow-up visit is probably not the right patient to do that type of surgery on. But somebody who is somewhat methodical and conscientious and understands what they're headed for might be an appropriate patient.